Hello everyone. In this section we are going to see about Raynaud's syndrome. Before we start, let me ask you something. Have any of you touched something very cold and noticed your finger suddenly turning pale or white? Most people ignore it, right? And say it is just the cold. But for some patient, that color change is actually a medical condition, and that condition is what we are studying today. I am Raynaud'S working as a tutor in Tribhulam College of Nursing. Okay, objectives of today's section is define Raynaud's disease, explain the etiology and pathophysiology, enumerate the clinical manifestation, list down the diagnostic studies, describe the management, discuss the nursing management. Alright, so a little background first. This condition is named after a French doctor called Marouin Raynaud. Interesting thing is, he was actually a medical student when he was first described this condition. That was in 1862. Now, you will hear this condition called by different names. Sometimes Raynaud's disease, sometimes Raynaud's syndrome, sometimes Raynaud's phenomenon. Now, why so many names for the same thing? The name used actually depends on whether there is an underlying cause or not. We'll understand this better when we get into classification. For now, just know all three names refer to the same basic problem. Okay. Now let's move into definition. Raynaud's phenomenon is an episodic vasospastic disorder of small cutaneous arteries, most frequently involving the fingers and toes. Episodic means it comes and goes in attacks. Vasospastic means blood vessels suddenly go into spasm and constrict. Small cutaneous arteries means the tiny vessels just under the skin. Fingers and toes most commonly affected. The core problem here is the small vessels overreacting to triggers and cutting off blood flow. That's what Raynaud's. Next we'll move into the classification. There are two types. It is a primary and secondary. Primary means no underlying disease. The vessels are just hypersensitive on their own. Milder, more common, mostly affects the younger women. And secondary Raynaud means an underlying condition is causing the problem. Less common but more serious. More severe attacks and more complication. Which means primary means no cause, secondary means something bigger is behind it. Next one is etiology. First is etiology of primary Raynaud's. So what triggers primary Raynaud's? Just two things, cold temperature and emotional stress. The patient is exposed to cold or they go through emotional stress and the blood vessels in their fingers and toes suddenly constrict. There is no disease, no injury, no medication causing it. The vessels are simply oversensitive. Even a cool breeze, picking up a cold glass of water or stepping into an air conditioned room can be enough to set off an attack. Next one is a etiology of secondary Raynaud's. The most common underlying condition is scleroderma. Scleroderma is a connective tissue disease where the body produces excess collagen and the skin and blood vessels become hardened and thicken. It is so closely linked to Raynaud's that if you see a patient with Raynaud's, you should always screen them for the scleroderma. Then we have systemic lupus erythematosus, rheumatoid arthritis and Sojourner's syndrome. All are autoimmune condition. Then arterial disease and carpal tunnel syndrome. Now, on the occupational side, this is very interesting clinically. Repetitive actions cause secondary Raynaud's, who specifically means typists, pianists, people who use vibrating equipment like jackhammers. The repeated vibration and pressure over time damage the small blood vessels and trigger this condition. This is why when you take history, you must always ask about occupational history. A jackhammer operator coming in with cold, pale fingers is very different picture from young women with no occupational exposure. Then hand and food injuries, exposure to chemicals, certain medications and smoking. Smoking is especially important. Nicotine is a vasoconstrictor, right? A patient with a Raynaud's whose smoke is making even very single attack worse. So if your patient smoking cessation is non-negotiable. Alright, now this is the most important slide, pathophysiology. Let us understand what actually happens during a Raynaud's attack step by step. First, the patient is exposed to cold or triggering factor. That trigger activates the sympathetic nervous system, which causes the small arteries in the fingers and toes to go into vasospasm. These tiny vessels constrict severely. What happens when blood vessels constrict? Blood flow drops, right? What happens when blood flow drops? Oxygen supply to the tissues also falls. So the fingers become pale because there is no blood reaching them. Now, one of the two things happen. Either the trigger is removed, maybe the patient goes into a warm room, or the body compensates on its own. The arteries begin to relax and dilate. Blood rushes back in. Now you have a sudden increased blood flow going into tissues that was starved. Because of this rush of reoxygenated blood, the color changes dramatically. So what color changes do you see means? Let me tell you the classic triphasic color change of Raynaud's. First, the fingers go white, that is a vasospasm phase. No blood, no oxygen, the tissue turns pale or white. Then they go blue. That is the cyanotic phase. The little bit of blood remaining is becoming deoxygenated, so the tissue turns bluish. Then they go red. That is the reperfusion phase. Blood rushes back in, the area becomes bright red, warm, and the patient feels a throbbing pain. White to blue to red. The triphasic color change is the hallmark of Raynaud's. If a patient tells you in the history that their fingers go through these three color changes with cold exposure, what is your first thought? Raynaud's. Remember this, it will come in your exam and in your clinical practice also. Okay, next one is clinical manifestation. The main manifestation is intermittent episodes of coldness, pain and pallor in the fingers or toes. During the attack, the affected parts feel ice cold and painful. After the attack, when blood flow returns, the patient feels numbness, tingling, a pins and needle sensation or a stinging pain. That is the tissue reacting to circulation coming back. Now look at the images on slide. These pictures show you exactly what a Raynaud's attack look like in real life. See the color of the fingers, that pallor, the triphasic change. This is why your patient hands will look like when they come to you. Recognize this visually is an important clinical sign. In severe cases, a repeated attack lead to ulceration of the fingertips. The skin breaks down because it is repeatedly starved of blood supply. And if it goes on even longer without management, we start seeing these complaints. Okay, next, how do we diagnose Raynaud's? What investigation do we do? Start with a thorough history, and in that history, occupational history is very important. Ask specifically what the patient does for work. Do they use vibrating tools? Are they a typist or pianist? This can directly point you to the cause. Physical examination then looks for the color changes and assess the circulation in the extremities. Next one is very important test, that is a cold stimulation test. This is a simple and direct test. You expose the patient hands to cold water and watch whether the characteristic color changes are triggered. It reproduces the attack in a controlled clinical setting. Next one is a nail fold capillaroscopy. Is done using a microscope to look at the tiny capillaries at the base of the fingernails. In secondary Raynaud's, particularly in scleroderma, these capillaries looks abnormal. These are enlarged and irregular. This is actually a very specific finding. Next one is a Doppler ultrasound. It measures blood flow in the digital arteries and tells you how severely circulation is compromised. And the blood test, which include ANA, ESR and CRP. Why are we doing this? to look for an underlying autoimmune disease. If ANA is positive, if ESR and CPR is elevated, means we start investigating about scleroderma, lupus erythematosus and rheumatoid arthritis. Because remember, if there is an underlying condition, this is secondary Raynaud's and the management is different. Okay, now we'll move into the important thing, medical management. So the very important step is avoiding triggers. This is not a medication, just a lifestyle modification. So we have to tell the patient to avoid cold exposure and wear gloves when they are going out, and ask them to avoid emotional stress, and most importantly advise them to stop smoking. This alone can significantly reduces the Raynaud attacks and severity. Next we'll move into the medication. So first choice is calcium channel blockers. Example is amlodipine. So what the calcium channel blockers will do means they relax the smooth muscle in blood vessel walls. So if it is relaxed, means less vasospasm and less attacks. And the next one is a antiplatelet agents like aspirin. So it will prevent the clot formation. And next vasodilators. Example is isosortin. It helps to dilate the blood vessels and improve circulation to the extremities. And the next drug is alpha blockers. Example is prazosin. It blocks the receptors that are responsible for triggering vasoconstriction. Okay. So this is about medical management. Next we'll move into the surgical management. The main surgery is a sympathectomy. So sympathetic means cutting or removing the sympathetic nerve supply to the affected area, so we could reduce the vasospasm response. The surgery involves removing sympathetic ganglia or cutting their branches. Next one is a chemical injection. It can achieve the same effect without open surgery by injecting chemical that block the sympathetic nerves directly. And in the most severe cases where tissue has already died and gangrene has set in, amputation becomes necessary to prevent the spread of infection. Okay, next one is a complication. If Raynaud's is not managed properly, means which leads to the complication. So what are all the complication means? Deformities of fingers and toes. So why means from repeated ischemic damage. Then skin atrophy, where the skin becomes thin and fragile. Then ulcers from skin breakdown due to poor blood supply, and gangrene when tissue dies completely from prolonged ischemia. Okay, next we'll move into the very important part and our role as a nurse, what we have to do. So we have to assess circulation, color, temperature and sensation in the extremities regularly and document everything clearly, and apply warm compress to the affected area during an attack. Warmth is the fastest relief and helps dilate the blood vessel. And administer prescribed medications, vasodilators, calcium channel blockers and alpha blockers. Then monitor for circulation every 2 hours using a circulation chart. Check the capillary refilling time, color, warmth and sensation and each round. And we have to educate the patient to avoid the triggering factors. So this is about the nursing management. Now let us close the section. So Raynaud affects about 40% of cases. So severe and repeated attacks leads to skin sores and gangrene. As a nurse, our role is to assess yearly, manage the triggers and give the right medication, monitor for circulation and educate the patient. Proper nursing care and patient education are what prevent this condition from reaching its worst complication. Okay, thank you.